All right, welcome to the deep dive. Today we're going microscopic. We're diving into the world of antimicrobials.
Yeah, these are the drugs that we rely on. These amazing medications like your antibiotics, your antifungals, and your antivirals.
And we're going to break it down, really understand how these things work, how they target those tiny invaders, but in a way that hopefully doesn't make your head spin.
Exactly. We want to give you a clear picture of this really, really important area of medicine. And for this deep dive, we've got a really great audio lecture that really digs into the pharmacology of these antimicrobials, plus a whole PDF document that's packed with info.
Perfect. So our goal is to, really pull out the most important stuff from all of that and give you a practical overview. And hopefully you'll be surprised by how interesting it is.
I think so. By the end of this, you'll have a much better grasp on, how these drugs can actually, pinpoint those little troublemakers, the microorganisms, without doing any damage to your own body.
Exactly. And we'll be covering, the main categories, your antibiotics, your antifungals, your antivirals, each tackling a different type of microbe. And then, of course, how they work on a cellular level, their spectrum of activity and, the big stuff like how resistance develops, potential side effects, all of that.
Right.
So I guess, to kick things off, let's talk about this idea of selective toxicity. This seems to be like the foundation of everything we're going to be talking about.
Yeah, it really is. This idea, the selective toxicity, it's at the heart of it all. Antimicrobial therapy, it's basically exploiting the fact that microorganisms, they have differences, biochemical differences from your own cells. So these drugs are designed to target those differences and disable the enemy without hurting the innocent bystanders.
I like that analogy.
Yeah, so for example, many antibacterial drugs, they're designed to go after the bacterial cell wall. And of course, your cells, they don't have this rigid outer layer. So the drug, it can disrupt the bacteria, but it leaves your cells completely untouched.
Okay, so it's kind of like, having a key that only fits the lock on the bacteria's door, right? Leaves your house safe and sound.
Exactly.
So when we're talking about antibacterial drugs, the antibiotics, we often hear these terms bacteriostatic and bactericidal. Can you explain what those mean, in simple terms?
Sure. So bacteriostatic drugs, it's kind of like hitting the pause button on bacterial growth. They're not necessarily killing the bacteria outright, but they're stopping them from multiplying. This gives your immune system, your body's natural defenses, the chance to catch up and eliminate those pathogens that are frozen in place.
Okay.
A good example of this is chloramphenicol. It's a bacteriostatic drug. So it's all about preventing the infection from spreading while your body does its work.
So it's like giving your immune system that extra time, that backup it needs.
Exactly.
And then you have the bactericidal drugs, which are the ones that go in for the kill, right?
You got it. Bactericidal drugs, they directly kill the bacteria. A classic example is penicillin. It doesn't just stop growth, it actually destroys them. Now, here's a really important point. Whether an antibiotic is static or cidal, it actually has nothing to do with its spectrum of activity.
Right.
Meaning whether it targets a narrow range of bacteria or a broad range. You can have a bacteriostatic drug that's effective against a lot of different bacteria, and the same goes for bactericidal drugs. So it's about the way it works, not necessarily who it can target.
So just to clarify, static is like pause, cidal is like kill, but the spectrum is like how many different types of bacteria it can go after.
Precisely.
Okay, perfect. Now, the source material also mentioned these terms. MIC and MBC, what are those?
Yes. So MIC stands for minimum inhibitory concentration. And this is basically the lowest concentration of a drug that you need to stop bacteria from growing. It's kind of like finding the minimum amount of, say, weed killer you need to stop those weeds from sprouting in your garden.
Okay, so you're looking for that sweet spot, just enough to get the job done.
Exactly. And in practice, the MIC is super important because it helps doctors choose the right dose of antibiotic for you. You want the lowest effective dose to minimize side effects while still effectively treating the infection.
Got it. And what about MBC? What's that all about?
So MBC stands for minimum bactericidal concentration. And this is the lowest concentration you need to actually kill the bacteria and not just stop them from growing. It's a little more stringent. In the lab, they look for a 99.9% reduction in the number of bacteria after a certain time.
Well, okay. So MIC is about stopping the spread, and MBC is about total annihilation.
You got it.
Okay, I think I'm getting that. So Let's move on to this idea of antibiotic spectrum. Our source talked about narrow, extended, and broad spectrum. Can you break that down?
Of course. So think of the spectrum as like the range of bacteria that an antibiotic can effectively target. Narrow spectrum antibiotics, they're like specialists, they're very picky. They only work against a specific type of bacteria or a very small group. A good example is isoniazid, which is mainly used for Mycobacterium tuberculosis, the bacteria that causes TB.
Okay, so it's like a sniper going after a specific target.
Exactly. Then you have extended spectrum antibiotics, which cover a bit more ground. They work against gram-positive bacteria and also some gram-negative bacteria.
Right.
Ampicillin is an example. It's like penicillin, but it's been modified to have this wider reach.
So they've widened the net a bit.
Exactly. And then you have the broad-spectrum antibiotics, which are kind of like the heavy artillery. They can affect a whole variety of bacteria, both gram-positive and gram-negative. Think tetracycline, fluoroquinolones, carbapenems, they're all examples.
Wow, so they just go after everything.
No, not exactly everything, but a wide range. Now, these are really useful when you don't know the exact cause of an infection and you need to act fast. But there's a downside.
I was just thinking about that. It's like if you wipe out all the bacteria, good and bad, what happens then?
That's the issue. Broad-spectrum antibiotics, they can disrupt your normal flora, the good bacteria that live in your gut. And this can lead to superinfections where other more resistant bacteria like Clostridium difficile can take over.
Right, I've heard about C. diff. That can be really bad.
It can be. That's why doctors try to be as specific as possible with antibiotic choices if they can.
Makes sense. Now, sometimes doctors use combinations of antibiotics. What's the thinking behind that?
Yeah, so there are definitely times when combining antibiotics can be really beneficial. One reason is synergism, which is when two antibiotics work better together than they would alone. A good example is combining a beta-lactam antibiotic like penicillin with an aminoglycoside. It can be really powerful against certain tough
This
infections.
is like a 1-2 punch. They work together.
Exactly. But true synergism is not that common. It's usually reserved for really complex or serious infections.
Right, so what about the downsides of combining?
Well, there are a few things to consider. Some antibiotics, especially those that kill bacteria, work best when the bacteria are actively dividing. If you combine them with a drug that stops bacterial growth, it can actually interfere with their effectiveness.
Oh, I see. So it's like one is trying to kill and the other is saying, hold on, stop growing.
Yeah, kind of. That's called antagonism. And another issue is that using multiple antibiotics can increase the risk of developing resistance. The more you use them, the more chances bacteria have to find ways to survive.
That makes sense. It's like you're giving them more opportunities to figure out how to beat the system.
Exactly. So it's a balancing act, and doctors have to weigh the benefits and risks carefully.
Definitely. Now, speaking of resistance, let's talk about that more. It's a big concern with all these antimicrobials, right?
Mhm.
How do bacteria actually become resistant to the drugs that are supposed to kill them?
Right. So antibiotic resistance, it's a huge problem, and it's mostly due to genetic changes in bacteria. They can change their DNA either temporarily or permanently in a way that allows them to survive the antibiotic.
So they're evolving, finding ways to adapt.
Exactly. And there are a few ways they do this. One is by changing the target site that the antibiotic normally binds to. If the antibiotic can't bind, it can't do its job. It's like changing the shape of a lock so the key no longer fits.
Okay.
Another way is by reducing the amount of drug that gets inside the bacteria. They can develop pumps that push the antibiotic back out or mechanisms that prevent it from entering in the first place. It's like building a wall to keep the enemy out.
So they're either changing the locks or building walls.
Exactly. And the third way is by producing enzymes that can inactivate the antibiotic. A good example is beta-lactamase, which can break down the beta-lactam ring found in penicillins and cephalosporins.
So it's like they're creating their own little weapons factory to fight back.
Right. And this resistance, it's fueled by a few things. Overprescribing antibiotics, especially for viral infections where they don't even work, that's a big one.
Yeah, I've definitely heard that message before. Antibiotics don't work for colds and flu.
Right. And not finishing a full course of antibiotics, that's another problem. If you stop early, some bacteria might survive and become resistant.
So it's super important to take the full course as directed.
Absolutely. And poor hygiene and infection control practices, those can also spread resistant bacteria. It's a complex issue, but we all have a role to play in using antibiotics responsibly.
Absolutely. Now, let's get into some specific drug classes, starting with the heavy hitters, the penicillins. We talked about them briefly, but can you tell us more about how they work and the different types?
Sure. So penicillins, they're bactericidal, meaning they kill bacteria, and they work by messing up the bacteria's ability to build their cell walls. Specifically, they block the formation of peptidoglycan, which is a key part of the cell wall structure. Without it, the bacteria basically bursts open and dies.
So it's like taking away the bricks that hold the house together.
Exactly. And there are different types of penicillins, each with its own strengths and weaknesses. You have the natural penicillins like penicillin G and penicillin V. Penicillin G is effective against a range of gram-positive and some gram-negative bacteria, as well as sporochetes, but it's easily broken down by those beta-lactamase enzymes we talked about. Penicillin V is a bit more stable in stomach acid, so it can be taken orally, which is more convenient.
So penicillin V is the pill form.
Exactly. Then you have the antistaphylococcal penicillins like methicillin, nafcillin, and oxacillin. These were designed to fight staph infections, especially those that produce beta-lactamases.
Okay.
They're good against methicillin-sensitive Staphylococcus aureus, or MSSA, but they don't work as well against gram-negative bacteria. It's
Mm,
worth noting that methicillin itself isn't really used anymore because it can cause kidney problems.
got it. Then there are the extended spectrum penicillins like ampicillin and amoxicillin.
Right. These have a wider reach against gram-negative bacteria. They're often used for respiratory infections, and amoxicillin is also used by dentists to prevent infections before certain procedures. And finally, you have the anti-pseudomonal penicillins, like piperacillin and ticarcillin. These are used for Pseudomonas aeruginosa, a tough bacteria that can cause serious problems, especially in hospitals.
Okay.
They're usually given by injection or infusion, and often they're combined with a beta-lactamase inhibitor, like clavulanic acid or tazobactam, to protect them from those bacterial enzymes.
So it's like giving the penicillin a shield.
Exactly.
Now, we talked about penicillin resistance, and those beta-lactamases are a big part of that, right?
Yes, definitely. Bacteria that produce beta-lactamases can break down penicillins, making them ineffective. It's a constant challenge, and doctors have to stay up to date on the latest resistance patterns to choose the right antibiotics.
And what about side effects with penicillins?
Generally, they're considered very safe, but like all drugs, they can have side effects. The most common is allergy, ranging from mild rashes to severe anaphylaxis. So if you have a penicillin allergy, it's really important to let your doctor know. They can also cause diarrhea, sometimes because of C. diff overgrowth, and in rare cases, they can cause neurological problems, especially in people with epilepsy. And high doses of some penicillins can affect blood clotting. So it's about weighing the benefits against the risks.
Okay, good to know. So let's move on to another big class, cephalosporins. They seem to work in a similar way to penicillins.
Yeah, they do. They also target the bacterial cell wall, and they also have that beta-lactam ring that can be broken down by some beta-lactamases. But generally, they tend to be a bit more resistant to those enzymes than penicillin.
Interesting.
And they're often grouped into generations, from first to fifth. As you go up in generations, they generally get better at fighting gram-negative bacteria, but might be less effective against some gram-positive ones.
So it's about choosing the right generation for this specific bacteria causing the infection.
Exactly. Now, most cephalosporins are given by injection or IV, but there are a few exceptions, like cephalexin and cefixime, that can be taken orally. And most of them are eliminated through the kidneys, so dosage adjustments might be needed for people with kidney problems. Ceftriaxone is an exception. It's mainly eliminated through the bile.
That's good to know. What about allergies? If you're allergic to penicillin, should you be worried about cephalosporins?
There is a small chance of cross-reactivity, meaning that if you're allergic to penicillin, you might also be allergic to cephalosporins. But the risk is pretty low, around 3 to 5%. However, if you've had a really severe reaction to penicillin, like anaphylaxis, it's best to avoid cephalosporins altogether. It's always best to talk to your doctor about your allergies.
Absolutely. Now let's talk about carbapenems like imipenem. These are known for being really broad spectrum, right?
Yeah, they are. Carbapenems like imipenem, meropenem, doropenem, and ertapenem, they're effective against a wide range of bacteria, including many that are resistant to other antibiotics. Imipenem is always given with cystatin, which prevents it from being broken down in the kidneys. Because they cover so many bacteria, they're often used for empiric therapy, which is when you need to start treatment quickly before you know exactly what's causing the infection. But they're usually reserved for more serious infections.
So they're like the big guns. Are there any downsides?
Well, they can cause side effects like nausea, vomiting, diarrhea. Sometimes they can cause changes in your blood cell counts, and in rare cases, they've been linked to neurological problems like seizures. So doctors weigh the benefits and risks carefully.
Right, makes sense. Now, what about vancomycin? It's famous for its use against MRSA, right?
You got it. Vancomycin is a really important antibiotic, especially for those life-threatening infections caused by methicillin-resistant Staphylococcus aureus, or MRSA. Now, the oral form of vancomycin is only used for a specific gut infection called C. diff colitis, but for other infections, it's given intravenously.
Interesting. So oral is just for that one specific gut infection.
Right. And vancomycin works a bit differently than penicillins and cephalosporins, although it also targets the bacterial cell wall. But it has some potential side effects that you should be aware of.
Yeah, like that red man syndrome I've heard about.
Right. That's not actually an allergic reaction, but it can cause flushing and redness in the upper body and face. It's usually caused by infusing the drug too quickly.
Okay,
Other side effects can include hearing problems, kidney damage, and inflammation of the veins. So it's a powerful drug, but it needs to be used carefully.
definitely. Now let's move on to tetracyclines. These are bacteriostatic and broad spectrum, right?
Yeah, that's right. They're effective against a lot of different bacteria, including gram-positive and gram-negative, and some other microbes like protozoa and spirochetes. Doxycycline, one type of tetracycline, is often used for acne and chlamydia.
Okay.
Now, tetracyclines work by binding to the ribosomes in bacteria, preventing them from making proteins.
So they're basically shutting down the protein factory.
Yeah, exactly. Now, a couple of things to remember. You shouldn't take them with dairy products or certain antacids or supplements because that can interfere with absorption.
Yeah.
And they can bind to tissues that are forming, like teeth and bones, which is why they're not given to young children or pregnant women.
Right, I've heard about that.
Other side effects can include stomach upset, liver problems, sensitivity to sunlight, dizziness, and in rare cases, hearing problems.
Okay, so a lot to consider with tetracyclines. Now, what about aminoglycosides, like gentamicin and tobramycin? These are known for being pretty strong, but also potentially toxic,
Yeah,
right?
that's a good summary. Aminoglycosides, they're really effective against a lot of gram-negative bacteria, especially those that are resistant to other drugs. They're bactericidal, meaning they kill the bacteria, and they work by targeting those bacterial ribosomes, causing them to misread genetic information and make faulty proteins.
So they're scrambling the instructions in the protein factory.
Exactly. But the problem is they can also cause some serious side effects.
Well, like,
Well, they can damage the kidneys in the inner ear, leading to hearing loss and balance problems. They can also cause allergic reactions and, in rare cases, muscle weakness or paralysis.
wow.
So they're usually given by injection or IV, except for neomycin, which is used topically. It's mostly eliminated through the kidneys. Dosages need to be adjusted for people with kidney problems. It's definitely a drug where the benefits need to outweigh the risks.
Definitely sounds like it. Now let's move on to macrolides, like erythromycin, clarithromycin, and azithromycin. These are often used as alternatives to penicillin, right?
Yeah, they are. Macrolides, they have a similar spectrum of activity to penicillin, and they're often used for people who are allergic to penicillin. They're generally considered bacteriostatic, meaning they stop bacterial growth, although they can sometimes kill bacteria at high concentrations. And they work by targeting those ribosomes, blocking a step called translocation, which is needed for protein synthesis.
Okay, so they're also messing with the protein factory, but in a different way.
Exactly. Now, erythromycin, it's not very stable in stomach acid, so it's often given in a coated form or as an ester. Clarithromycin and azithromycin are better absorbed, and they all have different distributions in the body and different elimination pathways, which is important for dosing.
And what about side effects?
Well, they can cause stomach upset, and some can cause hearing problems, especially erythromycin. They can also affect the liver, so they need to be used cautiously in people with liver problems. And they can prolong the QT interval on an EKG, which can be a concern for people with certain heart conditions.
Okay.
They can also interact with a lot of other drugs, especially erythromycin and clarithromycin, because they inhibit those liver enzymes that break down many medications. So it's important to be aware of those potential interactions.
Definitely. Now let's talk about clindamycin. It also targets that 50S ribosome, right?
Yeah, it does. It binds to that 50S subunit, preventing protein synthesis. It's mainly used for gram-positive bacteria and anaerobes, which are bacteria that don't need oxygen to survive. It's available both orally and intravenously, but the oral form can cause some stomach upset.
Okay.
Now, one thing to remember is that C. diff is always resistant to clindamycin. In fact, using clindamycin can increase the risk of developing C. diff infection, which can cause really bad diarrhea.
So it's good for some infections, but it can come with that risk.
Exactly.
Now, what about chloramphenicol? It sounds like this is a drug that's only used in very specific situations.
Yeah, you're right. Chloramphenicol, it's a broad spectrum antibiotic, but it's only used for very serious, life-threatening infections when there's no other option. And that's because it can have some really serious side effects.
Like what?
Well, it can cause different types of anemia, which is a problem with your red blood cells, and it can also cause something called gray baby syndrome in newborns, which can be fatal.
Wow, that sounds scary.
It is. So it's a drug of last resort, and it's used very cautiously.
Okay, that makes sense. Now let's move on to fluoroquinolones, like ciprofloxacin and levofloxacin. We talked about them earlier, or how they affect DNA replication. Can you expand on that?
Sure. So fluoroquinolones, they're bactericidal, meaning they kill bacteria, and they work by inhibiting two enzymes called DNA gyrase and topoisomerase thal, which are essential for the bacteria to replicate their DNA.
Yep.
Without those enzymes working properly, the bacteria's DNA gets all tangled up and they can't survive. They're effective against a lot of different bacteria, both gram-positive and gram-negative.
Okay.
Now, their absorption can be affected by certain things like antacids and some supplements, so you have to be careful about that. They can also reach high concentrations in certain tissues like bone and prostate, and most of them are eliminated through the kidneys, except for moxifloxacin, which is mainly eliminated through the liver. Now, there are some important side effects to be aware of. They can cause stomach upset, headache, dizziness, and they can make you more sensitive to sunlight. They can also cause joint and tendon problems, and in rare cases, tendon rupture. So they're usually avoided in pregnant women, breastfeeding women, and children.
Okay.
And they can also prolong the QT interval on an EKG, which is a measure of your heart's electrical activity. And they can interact with other drugs like warfarin, caffeine, and cyclosporine. So there's definitely a lot to consider with fluoroquinolones.
Sounds like it. Now, finally, let's talk about trimethoprim. It's often used in combination with sulfamethoxazole.
Yeah, you're right. Trimethoprim and sulfamethoxazole, they're often combined into a drug called cocrimoxazole, which is sometimes known as Bactrim or Spectra.
Okay, I've heard of those.
Now, they both interfere with folic acid synthesis, which is essential for bacteria to grow and divide. But they work at different points in the pathway, which is why the combination is so effective. Trimethoprim is actually much more potent than sulfamethoxazole on its own. Now, because they can affect human folic acid metabolism too, they can cause some side effects like anemia and low white blood cell counts, especially in pregnant women or people with poor diets. But those side effects can usually be reversed with a supplement called folinic acid.
So they're messing with the bacteria's ability to make essential building blocks, but they can also have an impact on us.
Exactly.
Okay, that was a really thorough overview of antibacterial drugs. Now let's switch gears and talk about antimycobacterial drugs, which are used for tuberculosis. What makes TB treatment so different?
Yeah, TB is a tough one. The bacteria that causes it, Mycobacterium tuberculosis, it's very slow growing and it has this really thick, waxy cell wall that contains mycolic acid. This makes it really hard to kill.
So it's like it's wearing armor.
Exactly.
Yeah.
And that's why TB treatment is so long and involves multiple drugs. The standard treatment usually involves 4 drugs for 2 months, followed by 2 drugs for another 4 months.
That's a long time.
It is. And the drugs used are isoniazid, rifampin, pyrazinamide, and ethambutol. Now, isoniazid, it specifically targets that mycolic acid synthesis, so it's really important for TB. It can cause liver problems, though, so people taking it need to be monitored closely.
Got it.
Rifampin, it blocks RNA transcription, which is how the bacteria make proteins. But a big thing with rifampin is that it interacts with a lot of other drugs, so dosages often need to be adjusted.
Okay.
Pyrazinamide, we're not totally sure how it works, but it's thought to work best in acidic environments, like those found in TB lesions. It can also cause liver problems and sometimes gout.
Okay.
And finally, ethambutol, it blocks another part of cell wall synthesis. But the big thing with ethambutol is that it can cause vision problems, so people taking it need to have their eyes checked regularly.
Wow. So TB treatment is really complex, and there are a lot of things to watch out for.
Definitely. It's a challenging infection to treat.
Okay, let's move on to antifungal drugs. Why don't the antibiotics we've been talking about work against fungi?
Right. So fungi, They're different from bacteria in a lot of ways. They're actually more similar to our own cells. They have a nucleus and other organelles that bacteria don't have, and their cell walls are made of different stuff.
Okay,
So antibiotics that target bacterial cell walls or bacterial ribosomes, they just don't work against fungi.
got it.
Now, fungal cell membranes contain a sterol called ergosterol, which is different from the cholesterol found in our cell membranes, and that's a good target for antifungal drugs.
Okay.
And fungal infections can be anything from, mild skin infections like athlete's foot to really serious systemic infections that can be life-threatening, especially for people with weakened immune systems.
Right, so it's a wide range of severity.
Exactly.
Now let's talk about some specific antifungals. Amphotericin B, it sounds like that's a pretty potent drug.
It is. Amphotericin B, it binds to that ergosterol in the fungal cell membrane and creates pores, basically punching holes in the membrane, which messes up the cell balance and leads to death.
So it's like poking holes in a balloon.
Exactly. But it can be toxic, especially to the kidneys. It can also cause fever, chills, and sometimes low blood pressure. So it's usually reserved for serious infections where other drugs haven't worked.
Okay, now what about nystatin? It's also a Pauline antifungal. Does it work similarly?
Yeah, it works in a similar way, but it's not absorbed very well from the gut. So it's mostly used topically for skin and mouth infections like thrush. It can also be used vaginally for yeast infections.
Yeah.
Because it's not really absorbed into the bloodstream, it's generally safer than amphotericin B.
Got it. Now, what about the azole antifungals like fluconazole and itraconazole?
Yeah, so azoles, they work by blocking the synthesis of ergosterol, that essential part of the fungal cell membrane. They basically prevent the fungi from making it properly, which weakens their membranes and inhibits their growth.
So they're stopping the fungi from building their defenses.
Exactly. Now, azoles can interact with other drugs that are broken down by liver enzymes, so that's something to be aware of.
Okay.
And they should be avoided during pregnancy.
Got it. Now, our source also mentioned a few other antifungal mechanisms.
Yeah, there are a few others. Echinocandins, they target the fungal cell wall. Alimamunes, like terbenafine, they also interfere with ergosterol synthesis, but at a different step than azoles. Flucytosine, it messes with the fungi's DNA and RNA synthesis. And grisofulvin, it interferes with cell division.
So lots of different ways to target those fungi.
Exactly.
Okay, let's move on to the final category. Antiviral drugs. What makes viruses so tricky to target?
Viruses, they're really unique. They're not even really considered living organisms because they can't replicate on their own. They need to hijack our cells to make more copies of themselves.
So they're like little pirates.
Yeah, kind of. And that makes it really hard to find drugs that can kill the virus without also killing our own cells.
Right, it's like trying to hit a target that's hiding behind a hostage.
Exactly. And to make matters worse, the symptoms of a viral infection often don't show up until the virus has already replicated a lot, making it harder to treat effectively.
Okay, so it's a real challenge. Let's start with antiviral drugs for respiratory viruses, like influenza. What about those neuraminidase inhibitors, like Tamiflu?
Right, so neuraminidase inhibitors like oseltamivir, Tamiflu, and zanamivir, Relenza, they work by blocking an enzyme called neuraminidase, which is important for the virus to spread from cell to cell.
Okay.
They're most effective if you take them within 48 hours of getting sick, and they can shorten the duration of the flu and make the symptoms less severe.
So they can help you feel better faster.
Yeah, they can. They can also be used to prevent the flu if you've been exposed to someone who's sick.
Got it. What about those older drugs, amantadine and romantadine?
Yeah, those used to be used for the flu, but unfortunately resistance has developed, so they're not really recommended anymore.
Yeah.
And they can cause more side effects than the neuraminidase inhibitors, like insomnia and dizziness.
Got it. Now, what about drugs for chronic viral hepatitis, like hepatitis B?
Yeah, so for chronic hepatitis B, one option is interferons. They're naturally occurring proteins that have antiviral activity. They can help boost your immune system's response to the virus, but they can also cause some flu-like side effects and sometimes depression.
Okay.
And then there are the nucleotide and nucleoside reverse transcriptase inhibitors, or NRTIs.
Okay.
These drugs block the enzyme that the virus uses to convert its RNA into DNA, which is essential for replication. Adefovir, Daboxil, and entecavir are two examples, but they can also cause some side effects, mainly kidney problems. Host speaker.